We present this case of a incarcerated hemorrhoid which are strangulated, irreducible state of internal hemorrhoids involving the entire or partial circumference of anus. This usually occurs following prolonged prolapse. As you can see, the prolapsed hemorrhoidal mass containing large amount of edematous fluid over the external part, and on compression large amount of fluid can be expressed, which reduces the size of the hemorrhoid. So basically, acute hemorrhoidal thrombosis or crisis result from prolapse, incarceration and thrombosis of internal or external hemorrhoids. Although the acute thrombosis and strangulation of hemorrhoid is a common condition, there is no consensus as to its most effective treatment. So now we are exploring and seeing that the patient has got a severe anal spasm, which we are releasing by doing a procedure what is known as sphincterolysis, wherein the internal sphincter fibers which have been spastic and fibrotic have been removed or have been fractured using thumb. Then the three principal sites of hemorrhoid, that is at 3, 7 and 11 o'clock position, or left lateral, right anterior and right posterior positions, are held with artery forceps so as to explore the and expose the hemorrhoid. The smaller hemorrhoids at 3 and 7 o'clock positions are being ablated using a radio frequency device which ably reduces the vascular component, and when it heals, it allows the hemorrhoidal mass to get fixed to the underlying structures, thus reducing the symptoms and fixing the hemorrhoid. So radiofrequency ablation creates ionic agitation and frictional heating within the tissue, creating a temperature of no more than 70 degrees Celsius, so no lateral thermal damages occur, and only the vascular component of the hemorrhoid is taken care of. One transfixing suture at the pedicle gives an additional obscuration or blockage of the blood supply to these hemorrhoids, and thus chances of their recurrence is further obviated. So one stitch at the pedicle is enough to obscure the blood supply. The acute thrombosis and strangulation of hemorrhoid is both painful and debilitating and a major cause of morbidity. While attempts have been made to establish a consensus for the treatment of chronic hemorrhoids, there is a little consistency in the management of patients presenting acutely. The older surgical texts advise the conservative approach, and many surgeons remain reluctant to operate on patients presenting as an emergency despite some evidence to contrary. Now we are taking a anchoring suture at the pedicle so as to reduce the blood supply and thus reducing bleeding while we dissect and remove this prolapsed thrombosed hemorrhoid. Venous congestion and soft tissue edema are usually accompanied to cause swelling. Symptoms of this situation include severe pain, bleeding more than moderate in amount, foul-odored discharge, and defecation difficulties. With aggravation, tissue necrosis and ulcer can be combined. Sometimes it is confused with prolapsed hemorrhoids and circumferential hemorrhoids. Prolapsed hemorrhoid refer to third or fourth degree internal hemorrhoids regardless of whether they are reducible or not. Circumferential hemorrhoids refer to those that involve the entire circumference of the anal verge. The term strangulated or irreducible prolapsed hemorrhoid like this is used together with incarcerated hemorrhoid. Now, the treatment options are generally classified into four kinds. One, emergency operation. Two, operation on the next day after reduction with local anesthesia. Three, delayed operation after conservative treatment. And the fourth, the restrictive operation, which insisted the conservative treatment after excision of one largest bile mass only. Now, one study reported the result of operation for 25 incarcerated hemorrhoid that was equally safe and effective compared with those with chronic internal hemorrhoids. We prefer emergency operation with hemorrhoidectomy. However, in the tradition ligation and excision method, much of the mucosa could be removed, which result in anal stricture or damage to or a part of the internal sphincter, causing weakness of the sphincter function. But if we are removing only one part of the hemorrhoidal segment, the stenosis and other complications can be prevented. So the entire hemorrhoidal mass is being excised and the pedicle and the base of the hemorrhoid is being secured, which will be fixed to the external wound. Acute prolapse, where the hemorrhoidal mass becomes trapped by the sphincter outside the anus, can lead to obstruction of venous return, edema, and strangulation. If untreated, this can be severely incapacitating for several weeks. Treatment are often conservative, including bed rest, analgesia, hot baths, ice packs, soothing topical application, and stool softeners. Resolution does eventually occur, but there is a high incidence of continuing symptoms. It was observed that the pedicles are usually unaffected and well defined, free of thrombosis and free of ulceration and inflammatory cells. So the pedicle ligature can always be successful and there are no chances of it getting sloughed off or suture slippage or infection leading to loosening of the pedicle suture. Immediate surgical treatment prevents the social and economical consequences of a prolonged recovery during conservative treatment and avoids the need for surgery at a later date. The timing of this surgery is important, however. The natural history of the condition is of spontaneous resolution over a few days, and the benefits of surgery therefore lessen with the improvement of symptoms. Now, once the bile mass has been excised, few bleeding points may need ablation. The patient is asked to use sitz bath, local application, and laxative for smooth bowel activity for next few weeks.